The recent IAP National Treatment Guidelines 2024 on the management of septic shock in children has a number of changes which might lead to a paradigm shift in our practices which we have learned till now. We all know it is a dysregulated host response to infection characterized by systemic inflammation, immune dysregulation, and microcirculatory derangements. But the specific clinical features on where the patient falls lies on the continuum, which ranges from sepsis to septic shock to multi-organ dysfunction syndrome. Basically, the key strategies of septic shock management include early recognition, timely initiation of appropriate antibiotics, source control, hemodynamic management, and supportive therapy. Sepsis in children is now identified using the Phoenix sepsis criteria, the details of which I have mentioned in a video which I have just released, and this includes potentially life-threatening organ dysfunction of respiratory system, cardiovascular system, coagulation, and or neurological system in children who have suspected or confirmed infection. So as per the Phoenix sepsis criteria, sepsis is suspected infection plus more than equal to 2 points on the Phoenix sepsis score, and septic shock is sepsis with more than equal to 1 cardiovascular point. The details of which you can see in an earlier video. I'll share the link of which in the description box below. Early recognition involves at least knowing the age appropriate values. Temperature less than 36 degrees centigrade, that is hypothermia, or more than 38 degrees centigrade, hyperthermia is detrimental. Tachycardia disproportionate to fever. It is said that for every 1 degree centigrade rise in temperature, heart rate can increase by 10. Silent or labored breathing. Systolic blood pressure less than 95th centile or wide or narrow pulse pressure. Now what is pulse pressure? Pulse pressure is the difference between systolic and diastolic blood pressure. Capillary refill time more than 3 seconds, that is delayed capillary filling, or less than 1 second, that is brisk or what is known as flash capillary refill, which is pathognomic of the septic shock. Peripheral pulses can be feeble as in hypovolemic or in cold shock, or they can be bounding as in vasodilatory shock. I shall be explaining the term later. Decreased urine output, altered sensorium. The child can be agitated if the hypoxia has just begun, early stages of hypoxia, or he can be depressed when the CNS has got injured to an extent because of persistent hypoxemia or shock. So we must be on the look for the red flag signs, which include age less than 3 months, immunocompromised patient, or having a history of recent hospitalization in the past 3 months. Hypothermia, mortal skin, capillary filling time more than 5 seconds or cyanosis, macular erythema, hypotension and low urine output, tachypnea with grunting, the child being unarousable, having poor response to pain, or having inappropriate cry, inconsolable, inappropriate cry. So in case any of these red flag signs are present, one must immediately start treatment by providing oxygen if SpO2 less than 92%, ensuring an IV or intraosseous access, obtaining blood cultures and blood gas, especially looking for the glucose and lactate values, correcting hypoglycemia and hypocalcemia, administering the first dose of antibiotic depending on the site and suspected etiology, and giving fluid resuscitation. Here I would like to mention that this is a significant change. This is 10 plus 10 ml per kg of ringer lactate or normal saline. Earlier it was said that we could go up to 60 and sometimes even up to 80 ml per kg of fluid, but now the fluid administration has become very judicious and restricted. They say that 10 ml per kg bolus along with 10 ml per kg bolus as a second bolus. The age-appropriate reference ranges of various vital parameters to identify shock are as follows. As regards heart rate, systolic blood pressure less than 5th centile, that is hypotension, and respiratory rate to identify tachypnea. These are the values given in the age less than 1 year, up to 5 years, up to 10 years, up to 16 years, and up to 18 years of age. So when you recognize a child having shock, that is the child having hypoperfusion, that is low urine output with or without hypotension, blood pressure is a late sign of shock, recognition of shock, because blood pressure is the body's, all the reflex mechanisms of the body try to maintain blood pressure to ensure circulation. So it is the last thing to fall down. So you must not recognize shock on the basis of blood pressure. So once you recognize shock, then you manage airway if required, if the child is altered or is having impending respiratory failure, and provide oxygen NIV or IV as required for breathing management. Secure 2 large bore IV cannulae for administration of fluid and other antibiotics. Obtain lab values of CBC, CRP or procalcitonin, ABG, electrolytes, calcium, sugar, 2 sets of blood cultures, one aerobic and the another anaerobic. Biochemistry for determining organ dysfunction to ensure whether the antibiotics would get excreted properly or not. That is liver function test and renal function test. We know that we have to do renal adjustment according in patients with AKI. After this, you administer the first dose of empirical antibiotic, which has to be selected depending on the suspected infection, the site of infection, local epidemiology, etc. And you give fluid bolus 10 to 20 ml per kg over 15 to 20 minutes, keeping a close watch on signs of fluid overload, including respiratory distress, oxygen requirement, and worsening shock. In case there is poor response, you label the patient as having fluid refractory shock. Now, fluid refractory shock can be vasodilatory shock. I shall explain these terms in subsequent scenes. Vasodilatory shock, you administer norepinephrine 0.05 to 0.2 microgram per kg per minute. Because norepinephrine is a potent alpha agonist with some beta adrenergic properties, which helps not only in improving vascular tone but also in increasing preload by recruiting fluids from the expanded venous bed. In short, you can understand in vasodilatory shock, the peripheral blood vessels. See, diastolic blood pressure is determined by peripheral vascular resistance. Diastolic blood pressure is determined by the peripheral vascular resistance, and systolic blood pressure is determined by the cardiac output. So, in case the diastolic blood pressure is low, this is a surrogate marker of peripheral vascular resistance being low. So, when will the peripheral vascular resistance being low? Will be low when there is peripheral vasodilatation. So, whenever there is peripheral vasodilatation, as we'll see in conditions like autonomic, neurogenic and septic shock, we must administer norepinephrine as the vasopressor of choice in a dose of 0.05 to 0.2 micrograms per kg per minute. In vasoconstrictor shock, like when the peripheral vascular resistance is increased, that is the diastolic blood pressure is increased, it is the systolic blood pressure which has fallen down. You need to give epinephrine 0.05 to 0.2 micrograms per kg per minute and use the peripheral dilution of these inotropes until and unless you have secured a central IV access. You need to escalate respiratory support if required and monitor invasive blood pressure and echocardiography. In case there is poor response to these vasoactive drugs, you label the patient as having catecholamine resistant shock and consider fluid bolus if the patient is responsive to the same. Correct anemia, give hydrocortisone, monitor 2D echo, look for LV, RV function, diastolic dysfunction, cardiac output, and central venous oxygen saturation. So, once the patient has catecholamine resistant shock, there can be 3 possibilities. First, the patient has hypotension with vasodilatory shock, I just explained. You titrate norepinephrine. Vasopressin also has similar mechanism of action. Vasopressin, the term itself means it is vasoconstrictor agent, and epinephrine on top of that if required. The second possibility is hypotension with septic myocardial dysfunction. Now, whenever there is myocardial dysfunction, cardiac output shall decrease and you need to titrate the doses of your inotropes. So, you titrate the dose of epinephrine. You begin with epinephrine and in case required, you consider norepinephrine as well. So, in shock with myocardial dysfunction and narrow pulse pressure, epinephrine is the initial vasoactive drug. It is given in a dose of more than 0.1 microgram per kg per minute. It is beta adrenergic as well as alpha agonist action. The third possibility can be that the patient has normal blood pressure, but hypoperfusion is persistent and septic myocardial dysfunction can or cannot be present. In that case, you give the patient dobutamine or milrinone. Consider diuresis if fluid overload. So persistent shock despite norepinephrine and epinephrine infusions must prompt in-depth assessment for underlying pathology, and instead of giving more fluids, and you need to give milrinone or dobutamine. If the endpoints are not met, or there is no resolution of shock, or the adequate indicators of clinical perfusion normotension are not achieved, you label the patient as having refractory shock, and you must consider ECMO after having ruled out RV dysfunction, pneumothorax, pericardial effusion, and high intra-abdominal pressure, which can be causes of obstructive shock. So this is basically the flowchart which has been given in the IAP NTG, and this is what I have prepared over here. Airway must be stabilized as a priority when we begin management of septic shock. Give supplemental oxygen or high flow nasal cannula or non-invasive ventilation in patients with hypoxemia. Intubate and mechanically ventilate if patient has unstable airway. Respiratory support actually minimizes the work of breathing and reduces consumption of oxygen, and therefore it helps in management of shock. But this can also be a high risk procedure, especially in unskilled or semi-skilled hands, because it carries a risk of peri-intubation sudden circulatory collapse of the patient. So the nugget is that the requirement of vasoactive drugs is not the sole indication for mechanical ventilation. But in my own practice, I have felt that whenever there is a need for acting the second vasoactive drug in the patient, in management of patients with shock, you must definitely intubate and mechanically ventilate, at least take the work of breathing from the patient in your hand. For antibiotic selection, take focused history and examination, cultures and further diagnostic samples. And if you're not able to identify the source on the basis of history and examination, you can even go for imaging studies. And source control measures should be undertaken, as foci of undrained infection may not respond to antibiotics alone, and they may require surgical drainage procedures. So the choice of empiric antibiotic depends on the suspected site, likely pathogen, immune status of the patient, local epidemiology, and community or nosocomial source. Rational antibiotic therapy based on national antibiotic policy given by the Indian Council of Medical Research has already been discussed by me in a separate video. I'll share the link of which below in the description box. You can go through the same. So basically, shock can be wide pulse pressure shock or vasodilatory shock, or narrow pulse pressure shock or vasoconstrictor shock. I would again like to remind you the concept. Blood pressure is determined by cardiac output into systemic vascular resistance. So cardiac output is basically the determinant of systolic blood pressure, and systemic vascular resistance basically determines the diastolic blood pressure. So whenever cardiac output decreases, in order to understand in simple terms, it is not very as simple as I am explaining, but more or less of the same type. When cardiac output decreases, systolic blood pressure decreases, and when systemic vascular resistance decreases, diastolic blood pressure decreases. So if diastolic blood pressure decreases greater than systolic blood pressure, the pulse pressure, which is the difference between systolic blood pressure and diastolic blood pressure, that will increase, become more than 40. In that case, the patient will have wide pulse pressure or vasodilatory shock. But in case systolic blood pressure decreases and diastolic remains more or less the same, the pulse pressure, that is difference between systolic and diastolic blood pressure, will narrow, and this is referred to as vasoconstrictor or narrow pulse pressure shock. So vasodilatory shock is basically when diastolic blood pressure is less than equal to half of systolic blood pressure at that time, or pulse pressure is more than 140 millimeters mercury. Actually, we know that the normal blood pressure in an adult is 120 by 80 millimeters mercury. So 120 minus 80 will be equal to 40 millimeters of mercury. This is on an average the normal pulse pressure. So if pulse pressure becomes more than 40 millimeters mercury, it is referred to as wide pulse pressure. And in case these conditions are associated with tachycardia and warm extremities, this is what we get in vasodilatory shock. Classical examples of which include autonomic, neurogenic, and septic shock. Classical examples of vasoconstrictor narrow pulse pressure shock include hypovolemic and cardiogenic shock. Predicting fluid responsiveness in ICU is advantageous because it may help us in preventing the occurrence of fluid overload, which is even more dangerous, leading to more organ injury with the times we have realized that fluid overload is more dangerous rather than fluid deficit. Dynamic indices of fluid responsiveness include pulse pressure variation, stroke volume variation, and systolic pressure variation. As you can see the parameters over here. These are referred to as dynamic indices because they reflect the cardiorespiratory interactions in the real time. And currently, these are the most reliable techniques for assessing fluid responsiveness as per IAP NTG. So this is a graph. Here you can see maximum pulse pressure and minimum pulse pressure and systolic pressure variation. But the caveat with these indices is that the performance of these tests requires rigid criteria. And these rigid criteria are that the patient should be on mechanical ventilation with tidal volumes of at least 8 ml per kg, having no spontaneous breathing, and there should be no right ventricular dysfunction. All these three criteria, it is very difficult that these criteria not be present in patients who are in ICU. So these indices might not be that useful. Pulse pressure variation is defined as maximum pulse pressure minus minimum pulse pressure upon the mean of pulse pressure, mean of maximum and minimum pulse pressure into 100, and a pulse pressure variation of more than 12%. It is indicated as a percentage. So more than 12% indicates a fluid responsive state. Now when the patient is not mechanically ventilated, then how can we assess whether or not the patient is fluid responsive? Passive leg raising is a simple test which we can perform in spontaneously breathing patients, but the problem with this is that we need to measure the cardiac output to demonstrate increase in cardiac output. It is a test which predicts whether cardiac output will increase with volume expansion. In this test, we raise the legs and a volume of around 300 ml in adults of venous blood is transferred from the lower body towards the right heart. And this thus mimics a fluid challenge. Actually, no fluid is being administered. It is the blood which is pooled in the lower part of the body which is pushed towards the heart suddenly. So this test has the advantage of remaining reliable in conditions when the dynamic indices cannot be relied upon, like patients with spontaneous breathing, arrhythmias, low tidal volume ventilation, and low lung compliance. Also, non-invasive cardiac output devices are alternative tools to measure hemodynamic variables such as cardiac output, stroke volume, and arterial tone, but they lack accuracy to a great extent. Functional echocardiography provides comprehensive cardiac assessment including response to therapy. Basic information like pericardial tamponade, LV dysfunction, and IVC assessment can be done by residents also. But advanced training will lead us to a more comprehensive assessment including right ventricular function, diastolic function, stroke volume, and systemic vascular resistance index. As evident till now, whatever has been discussed, with that it is evident quite evident by now that septic shock is primarily a hyperdynamic state with elevated stroke volume and low systemic vascular resistance index because it is a vasodilatory shock state. It manifests with variable degrees of altered vascular tone, septic myocardial dysfunction, and deranged regional blood flow, and therefore actually the management of septic shock requires an individualized approach towards the management of each and every patient depending on his own intrinsic features as well as the disease characteristics. And one size fits all approach cannot be used. Rather, this approach cannot be used in any disease. The choice of fluid for resuscitation in septic shock is debatable, and crystalloids are preferred to colloids for early resuscitation. Balanced fluids should be considered for large volume resuscitation. While colloids do not have a mortality benefit compared to crystalloids, their use may be associated with decreased fluid overload. So this is something contrary to the belief till date, like colloids are associated with decreased fluid overload. Earlier it was believed that colloids would lead to more fluid overload. They also lead to lesser vasopressor requirement and organ dysfunction scores. Some patients may exhibit shock due to catecholamine excess, like if you have administered epinephrine or norepinephrine to a great extent, a lot of vasoconstriction has occurred, and this leads to diastolic dysfunction. So In these kinds of patients, gradual weaning of catecholamiine may be helpful along with close monitoring, and lucitropic agents such as milrinone, which is an inodilator, they should be used for diastolic dysfunction. If signs of organ hypoperfusion remain despite optimizing blood pressures, initiating dobutamine or milrinone infusions may improve cardiac output and microcirculation. Once the indicators of clinical perfusion such as blood pressure and other hemodynamic variables are optimized, de-resuscitation should be commenced and weaning of support may be initiated even in the initial 24 hours provided close monitoring is assured. Diuretics can be considered for oliguria or fluid overload once the blood pressures are sustained above the 5th centile and there is no requirement for escalation of vasoactive drugs. So this is also something which I think had not been mentioned in the earlier guidelines. I'm not very sure, but I think this is something new for me, even though I've been using the same. Broad spectrum antibiotics should be narrowed based on the antibiogram, which is very important step, especially to prevent antibiotic resistance. Supportive care in the form of ventilatory support should be given if required. In addition to the standard lung protective strategies, which include tidal volume of 5 to 6 ml per kg and plateau pressure less than 30 centimeters water, patients who have right ventricular dysfunction, they can benefit more by restricting the plateau pressures to not less than 30 but to less than 25 centimeters water, avoiding hypercapnia and hypoxemia and maintaining pH more than 7.3. With the addition of low-dose corticosteroids and catecholamine resistant shock can be beneficial, but there is no strong evidence for the same. Early steroids, however, are definitely advocated in patients with chronic corticosteroid exposure, for example, patients of nephrotic landing into septic shock. Here you must definitely consider giving steroids. Hypothalamic pituitary adrenal axis disorders and congenital adrenal hyperplasia. In children who are hemodynamically unstable with an oxygen deficit, a hemoglobin level between 7 to 10 grams per deciliter can be considered along with other measures to optimize oxygen delivery. Enteral nutrition can be commenced within 48 hours and must be considered after hemodynamic resuscitation in patients who no longer need vasoactive escalation. So this is another different thing which I think has been mentioned. Earlier it was believed that if the patient is on vasoactive medications, you avoid giving drugs, but in case the patient is not requiring escalation, whether or not the patient is getting de-escalated, this is not clear in these guidelines. You must start with enteral nutrition. Extracorporeal therapy such as renal replacement therapy and veno-arterial ECMO is a rescue therapy in children with septic shock refractory to all other treatments as we had seen in the algorithm earlier. So the major changes or the shifts in practice which I have perceived as per these guidelines are that the volume of fluid for resuscitation has changed both in number, that is you give only one fluid bolus, and volume 10 to 20 ml per kg over 15 to 20 minutes. The second significant thing I noticed was that no definite time points have been defined as to up to what extent would you consider giving inotropes after which you would label the patient as having catecholamine resistant shock. Like for fluid, it has mentioned you give the fluid for 15 to 20 minutes, no improvement, you label the patient as having fluid refractory shock. But after giving catecholamine for how long, you would label the patient as having catecholamine resistant shock, so on and so forth. Colloids are being preferred for the management, and colloids are known to decrease fluid overload, which I think is contrary to the belief till now. The use of diuretics have been clearly mentioned in these guidelines, and introduction of enteral nutrition has been advised if there is no escalation of vasoactive agents. So to summarize, early recognition of septic shock is must. Fluid resuscitation and vasoactive drug therapy should be individualized based on hemodynamic derangements, and this strategy also prevents treatment complications instead of a one-size-fits-all approach. Early appropriate antimicrobial therapy should be instituted ASAP. Source control of infection is very crucial because unless and until you do so, the patient would not improve, howsoever much antibiotics and all you give. And timely de-escalation should also be considered, considering the increasing risk of complications. But the most important thing is frequent and close monitoring repeatedly. And this is what the crux of intensive care means, that you must monitor the patient frequently and monitor the patient very closely. So thank you so very much for a very patient listening and watching. If you like the video, do give a thumbs up. I have personally been using the concepts of wide and narrow pulse pressure shock in my practice for the past 7 years. But what do you think? What is your practice of introducing vasopressors and inotropes? I'll be glad if you write it in the comment section below and interact. Thank you so much. Thanks a lot.